Okay.
Dr. Dan? Yeah, right. Okay.
I just changed the title.
Title, yeah.
Okay.
So I will also change.
No more changes allowed. Okay, we'll start in 2 minutes. Okay, so I think we could start, Daniel. Is that okay?
Sure.
Okay, so yeah, actually yesterday we had one of our senior neurologists. He also spoke on brainstem disorders in eyes. So it's going to be a little revision for everybody. It will be nice. I wish we could, I'm in the process of doing that, but maybe in the next month when we start having talks, we'll be able to have online questions and having a proper, you put up a case and ask people questions and they do that. Just now it's not there. So otherwise it could have been fun. So
okay.
you can go ahead. We're already 2:50, so we can start.
Sounds good. Can you tell me what was spoken about specifically yesterday, just so I have an idea of
INO and gaze disorder, crossed hemiparesis, and eyes in stroke and things like that. So just go ahead. There's no problem.
Okay, good. So I'm not going to talk about those things. I will have one single slide on INO because I'm just assuming that this audience knows how to recognize an INO. And this is going to be even more sophisticated. What other kinds of MLF or syndromes can you see with a stroke, for instance? So this is 100% ocular motor. Again, lots of videos, lots of figures, and okay.
If there is something on skew, we love it because we still don't understand skew detail.
You know, when I'm giving a talk, I have to talk about skew.
Yes, good. Okay.
Okay.
So, go ahead.
All right. So brainstem disorders. So thanks for inviting me back. I hope everyone is safe and staying busy in some way. So again, all the videos I show here and lots more are contained within my collection, which is free for anybody to access. And feel free to shoot me an email if you have an interesting case or video. I'm happy to help. And I always like to see new things as well. So here's what I will talk about. So the lateral medullary syndrome, the sort of most common ocular motor features, including saccadic dysmetria, which I know we've seen and we've heard about. Utricle imbalance, again, got to talk about the skew. Medial longitudinal syndrome. I will not talk about INO. I will talk about utricle imbalance and the vestibulo-ocular reflex, as well as nystagmus. And I'm going to spend a couple slides on oculopalatal tremor as well. So lateral medullary Wallenberg syndrome, if these are some of these things you heard yesterday, there's definitely some overlap with some of David Z's talks, with my bedside ocular motor talk as well. So repetition is the best way to learn this. I will show different videos than what I showed previously, so you can test yourselves. And I will have no idea if you get them right or wrong. So first we'll talk about saccadic dysmetria and ocular lateropulsion, what they are, what they look like. So first of all, tell me this patient has a lateral medullary stroke. Is it on the right or on the left? Can you tell simply by looking at the saccades? Yes, you can. So when she's looking to the left, she overshoots. When she looks to the right, she undershoots. That's a hypometric saccade to the right. When she's making a saccade to the left, she goes past the target and has to come back. So it's hypermetric to the left, hypometric to the right. I'm telling you, this is a lateral medullary syndrome, so this has to be on the left side. Highly localizing. The other thing you see here now is the ocular lateropulsion. So behind closed lids, she's closing her eyes. The eyes drift to the left toward the side of the lesion, and they come back to the right.
Dan,
So
can you show the video earlier that you have made it slow motion to show the overshoot?
Yep. I didn't label the slow motion. Let me try to find it.
You can show the actual speed and then the slow motion.
Yep. So this is slow motion. This is the hypometric. You see it takes a couple of little saccades to get to the target again. Rightward saccade, hypometric. It takes 3 little saccades. This is slow motion, hypermetric saccade to the left, where she's overshooting the target. And hopefully everyone can appreciate that. And again, toward the same direction, the same side where there's the hypermetria, you're also going to see the lateral, the ocular lateropulsion to the left. And again, behind closed lids, the eyes drift to the left, open the eyes have to come back to center to find the target. Okay, so Dr. Z talked about sort of the saccade pathways, which I'm not going to get into anything that's outside of the posterior fossa really, but the saccade-related cortical eye fields have significant projections to the superior colliculus. The superior colliculus serves as sort of the relay station. It integrates lots of these saccade commands coming from all over the place and projects onto mainly the brainstem structures, and the posterior fossa saccade circuitry involves structures in both the brainstem and the cerebellum. So seen here is the brainstem. This is sort of superimposed on it. We're going to talk about these midline structures in the cerebellum, the vestigial nucleus and the dorsal vermis, which are integrated into this one figure, which I'll continue to show going forward now. So the main structures that we care about in the saccade circuitry, this loop, is the inferior olive. These fibers are going to decussate via and climb via the inferior cerebellar peduncle to the dorsal vermis, where we have these Purkinje cells. These Purkinje cells are going to project onto the vestigial nucleus. The vestigial nucleus has excitatory signals, which it sends to the contralateral PPRF, paramedian pontine reticular formation, which is going to project then onto the 6 nuclei and indirectly via the inhibitory burst neurons onto the opposite side's 6 nuclei, so that we can have reciprocal innervation, that is, excitation of one side with simultaneous inhibition of the other side. The other thing to note here is that if you have a vestigial nucleus lesion, even if it's unilateral, you're going to take out both sides. You're going to have bilaterally hypermetric saccades with a unilateral vestigial nucleus lesion, because much like the superior rectus fibers, they start in one subnucleus, they immediately decussate over to the opposite side's nucleus. So if you have a unilateral nuclear lesion, you can have, again, bilateral vestigial injury effectively. If you have a unilateral a stroke involving the nucleus of the third nerve, then you will have bilateral superior rectus paresis as well. So again, we have this excitatory burst neuron, this EBN, which is within the PPRF, inhibitory burst neuron, the IBN pair, and this allows for excitation on one side with simultaneous inhibition on the other side. This is an example of reciprocal innervation. So if you desire a rightward saccade, what happens? So the right EBN is going to excite the right 6 nucleus, which is going to move both of the eyes to the right side. And this excitation via the vestigial nucleus is simultaneously going to excite the inhibitory burst neuron, the IBN, which is going to inhibit the left 6 nucleus, that is preventing the eyes from moving to the left. So in two ways, directly and indirectly, you're able to move the eyes to the right side. So what happens if you have a lesion within this circuitry, within this pathway? So here we have a left lateral medullary stroke. So because you have a stroke that involves the climbing fibers after they decussate from the inferior olive, you're disrupting the climbing fiber, the ICP inputs to the dorsal vermis. Because you have less inhibition of this inhibitory structure, you're going to disinhibit it. So it's going to then inhibit the ipsilateral vestigial nucleus even more than it normally would. If you have increased inhibition of the vestigial nucleus, then you're going to decrease excitation to the contralateral, the contralesional EBN IBN pair. This is going to be responsible for this ipsipulsion, this left lateral pulsion, or hypermetric saccades to the left and hypometric saccades to the right. So if you have less right IBN output, that is from here, you're going to have less inhibition on the left side of the left 6 nucleus. The left 6 nucleus is going to move the eyes to the left. And simultaneously, if you have less right EBN output, you're going to have less excitation of the contralesional right 6 nucleus. The combination of those two things are going to drive the eyes to the left side, toward the side of the lesion, hence the term ipsipulsion, because we're going toward the side of the lesion. Also known as left ocular lateral pulsion in this situation. Oftentimes, because of the ICP disruption, patients will have hemiataxia on the left side of their bodies. They'll also have lateral pulsion when they're trying to walk. They will lean or veer toward the left side in the same direction as the ipsipulsion or the ocular lateral pulsion. So everything is in the same direction. Here's another example. So left lateral medullary lesion, behind closed eyelids. The eyes are really going to deviate to the left side. You open the eyes, the patient has to look back to center, so the eyes have to come to the right. And again, this is another example of a left lateral medullary problem causing leftward ocular lateral pulsion, also known as ipsipulsion, because it's toward the side of the lesion. So this is what you're going to see. So toward the side of the lesion, you're going to see hypermetric saccades and ipsipulsion. Away from the side of the lesion with a Wallenberg, you will see hypometric saccades, as I showed before. So what happens if in the same circuit, you've had a lesion that's in the medial medulla? So this is before the climbing fibers decussate. If you have a stroke, you will have, because you're affecting the same pathway in exactly the same way, just on the opposite side of the midline, the eyes will still go to the left side. Likewise, if you have a lesion that affects the right superior cerebellar peduncle up here as a result of a demyelinating lesion in multiple sclerosis, for instance, because you're affecting the end result of disrupting this pathway will be exactly the same, in that you will have less excitation of the right-sided EBN-IBN pair. The eyes will go to the left. So it's the same thing as I just showed you with the left lateral medullary lesion, but now we're on the right side. So for that reason, this is now called contrapulsion, because you have a right-sided lesion, the eyes go to the left. If you had a left lateral medullary stroke, it would be ipsipulsion, because the eyes are going toward the side of the lesion, but it's the same exact pathway. The end result of multiple lesions here, here, or here will be exactly the same. So it's all about the company it keeps. So if you have a medial medullary lesion, you might also have upbeat nystagmus. If you have superior cerebellar peduncle lesion, you might have ataxia on the opposite side. That can help you to localize. You might have other ocular motor features that give you clues as to where the problem is. Here's another example. The other thing to know is that if you ask a patient who has ipsi or contrapulsion to make vertical saccades, oftentimes they'll deviate toward the side of the lesion. So an upward saccade kind of has this trajectory. Downward saccade has this trajectory. So that's to the right. When she closes her eyelids, the eyes drift to the right side and they have to come back to the left. So this patient has a right-sided lateral medullary lesion or a right-sided Wallenberg. The other thing that you may see, that you will commonly see in these patients, is ocular lateral pulsion reflected, as in this case, on the MRI. That by itself can't differentiate whether the patient has the acute vestibular syndrome due to a central process like a brainstem stroke or a peripheral process like vestibular neuritis. Clinical ocular lateral pulsion, if you see something that looks like this, is always central. However, radiographic lateral pulsion can also be peripheral. Here's a paper that was written specifically about this. They had 6 or so cases of vestibular neuritis where the patients basically all had this ocular lateral pulsion that was seen on the MRI. This has been my experience as well, that if you look hard on a patient with vestibular neuritis, in this case, a right-sided vestibular neuritis might cause rightward ocular lateral pulsion. That by itself doesn't mean anything. But if you're sitting there with the patient and they have ocular lateral pulsion that looked like hers did, then that is central. The exact underlying mechanisms are not so clear as to why patients with the acute vestibular syndrome due to vestibular neuritis can have this degree of ocular lateral pulsion. But just know, if you see this on an MRI, this does not automatically imply that the patient has a central etiology. If you see what she had on her exam, the rightward deviation of vertical saccades and rightward ocular lateral pulsion, and this, then that's highly concerning for a central problem. So what about the utricle-ocular motor reflex, the utricle-ocular motor pathway? So here's the labyrinth, here's the utricle. The utricle is innervated by the superior division of the vestibular nerve. It is the linear acceleration detector. It responds to translation, side to side, forward and back, as well as head tilt. We care mainly about its function, its role in head tilt in the example of the skew deviation. This is a similar slide or the same slide to what I showed a couple weeks ago. This is the physiologic ocular tilt reaction. Here's the review that almost made my head explode after I read it 50 times, but you should read it if you have any interest in this. It's a really good paper. It breaks it down sort of in baby steps, which is very helpful for this kind of complicated concept. I myself needed it broken down into sort of baby steps. That's the way to look at this. So let's say that you are, again, on your motorcycle, you're going around a curve to the right. What's going to happen? So the head is going to tilt to the right with the around the curve. That's going to fire the right utricle. If you activate the right utricle, the right eye is going to elevate, the left eye is going to depress. That skewing in a normal person is very small. It's very minute. There's a little bit more of this ocular counter roll. That is, the top poles are going to go towards the left ear. But mainly in a normal person, you're going to see this reorientation of the head relative to gravitational vertical. That's the biggest way that a patient who's tilting is going to sort of get back to center, get back to earth vertical. So let's say you have left-sided utricle pathway destruction, as in the case of a left-sided lateral medullary stroke or a Wallenberg syndrome. In this case, there's relative hypoactivity of the left utricle and relative hyperactivity of the right utricle. So the brain senses that because this is relatively hyperactive relative to the left side, that the brain could be tilting to the right side, like this guy who's going around a curve on the motorcycle. So if the brain thinks that you're tilting your head to the right, even though you're not, in an effort to compensate for that, for this perceived right head tilt, the patient will tilt their head in the opposite direction to try to compensate, like this gentleman. But this gentleman is using his physiologic ocular tilt reaction to get back to gravitational vertical. This patient, who has a pathologic ocular tilt reaction, thinks that they started to the right when in fact they started here. So instead of going from right to center, they're going from center to left. This is what they now think is their gravitational vertical, even though that's not the case. So this is a pathologic ocular tilt reaction, but it is also compensatory in a way. It's the brain's, the brain is trying to get back to gravitational vertical, what it perceives to be gravitational vertical. In this case, you're going to see a pathologic skew. The right eye will come up, the left eye will come down, and you're going to see this ocular counter roll. So this is the ocular tilt reaction, the triad of ocular, head tilt, skew deviation, and ocular counter roll. And here it is in action. So this is the same patient I showed who had the leftward ocular lateral repulsion. She has a left-sided Wallenberg. And here, the left eye is the lower eye. Left eye comes up, right eye comes down. Left eye comes up, right eye comes down. So the left eye is the lower eye. She has a leftward head tilt. She also has an ocular counter roll with the top poles toward the left ear. So everything's in the same direction. The eyes are going to roll in the same direction as the head tilt. So if you have a left medullary lesion, we would refer to this ocular tilt reaction as ipsiversive, because everything rolls, everything is tilted in the direction of the lesion. So ipsipulsion and ipsiversion with a medullary lesion, a Wallenberg syndrome. We can also use the rule low-low. So what does this mean? So, the utricle ocular motor pathways decussate, they cross over at the pontomedullary junction. So at the level of the vestibular nucleus, at the level of a Wallenberg, where we've affected the inferior cerebellar peduncle, we are lower than this decussation. We are on the left side. This is the same example of a left lateral medullary Wallenberg syndrome, the same patient that I just showed. Here is a clear example of the left eye being lower on the side of the lesion. And we can use this low-low rule. That is, The hypotropic or lower eye is going to be on the same side as the lesion if the injury occurs caudal to, lower than, the decussation of the utricular-ocular motor pathway. So low. We are lower than the decussation, and the ipsilesional eye is the lower eye. Low. What about nystagmus and medullary syndromes? So this patient has a very nice, this is the video oculography with infrared goggles, the goggles that we use most of the time in the emergency department. This is a patient in the emergency department, are monocular. They only have a camera over the right eye, but the left eye is doing the exact same thing. So this is left beating torsional nystagmus. There's a nice mixed component of torsion and horizontal nystagmus. This is exactly what you would expect to see if a patient has vestibular neuritis due to peripheral semicircular canal imbalance. This is why we have this nystagmus. And in vertical gaze and straight ahead gaze, it's been unidirectional. That is, it's been left beating torsional in all directions. Here it is, it increases a little bit in left gaze. This is in accordance with Alexander's law. That is, the nystagmus is going to increase in the direction of the fast phase. And most importantly, when the patient looks to the right, we want to see if the direction of the nystagmus changes. And clearly it doesn't. Even though he's looking to the right, it's still left beating. This is unidirectional mixed horizontal torsional nystagmus. This is exactly what you would expect to see with acute vestibular neuritis. This patient was just a couple of hours from his onset. This is what you would expect to see. But remember that these afferents that are leaving the right labyrinth, in this case, he had left beating nystagmus. He had a head impulse that was abnormal on the right side, so that the nystagmus is going to be contralesional. So if you have a right labyrinthine or right vestibular nerve injury, this is exactly what you would expect to see. But those afferents leaving the right labyrinth immediately go to the vestibular nuclei and synapse. So you can have, with a vestibular nuclear lesion, you can have very similar patterns or patterns that look exactly the same as it would with a peripheral lesion. So patients who have unidirectional nystagmus, this can be peripheral or central. This is why it's a three-step test. The Hintz exam, the head impulse nystagmus test of skew test that you should be applying to patients with the acute vestibular syndrome. This is why it's a three-step test and not a one-step test. That being said, we're talking about the lateral medullary syndrome mainly, where the medial vestibular nucleus, these medial structures are being spared. But this is one pattern that you can see if you have a medullary stroke or some problem that affects the medulla. You can absolutely have unidirectional nystagmus. What about the medulla and gaze evoked? So this patient looks to the right, she has right beating. She looks to the left, she has left beating. She looks to the right, she has right beating. This is clearly gaze evoked. This is a patient who has thiamine deficiency due to Wernicke's encephalopathy. And in this kind of situation, the midline structures tend to be affected. Again, that we're not talking about a lateral medullary syndrome. Now we're talking about more sort of medial medullary injury, mainly the MVN, the medial vestibular nucleus, the NPH, the nucleus prepositus hypoglossi. This complex is responsible for horizontal gaze holding. So you can have horizontal gaze holding, horizontal gaze evoked nystagmus from a medullary lesion as well, a medial medullary lesion. What about torsional nystagmus? This is another common pattern that you might see with a medullary stroke. This patient has pure torsional nystagmus with the top poles beating toward the right ear. This patient had a tumor that involved the left medulla. And when you see pure torsional nystagmus, it's almost always central with rare exceptions. And the reason is, to get pure right beating nystagmus, you would have to strategically take out this canal and this canal. And it's just hard for that to happen. Hard for you to spare this canal and this one and this one and this one and just take out the two vertical semicircular canals on one side. So it's just hard to do on a peripheral basis. It's much easier to do as you affect the pathways centrally in the brainstem, for instance. What about upbeat nystagmus? This is another example of thiamine deficiency. And again, Wernicke's encephalopathy tends to affect these midline brainstem structures. In this situation, the nucleus of roller nucleus intercalatus were affected, causing upbeat nystagmus. Again, now we're talking about the medial medulla. We're not talking about the lateral medulla. You would not expect to see upbeat nystagmus in a Wallenberg syndrome. But if you see pure upbeat nystagmus, this is commonly due to bilateral midline medullary or pontomedullary lesions. Now we're going to talk about the MLF syndrome. Like I said, this is the one slide dedicated to an internuclear ophthalmoplegia. And in this case, this patient, when asked to look to the right, you see this adduction deficit and this slow adducting saccade to the right side. This was a great patient. Unfortunately, I wasn't around to take the video. My fellow took the video for me, and it's just not as good as I'm accustomed to. But you can also see the abducting nystagmus to the right over here. You see the adduction lag, the adduction deficit, plus the abducting nystagmus. This is highly suggestive of a left internuclear ophthalmoplegia due to left medial longitudinal fasciculus injury. In his case, he had a stroke that just affected the left MLF and nothing else.
Dan,
yes.
This video is very good actually to show the lag of the medial rectus, and therefore to look at the bridge of the nose and appreciate the two eyes diverging. Just let everybody see that. I mean, when you look at the bridge of the nose, then you see that the two eyes diverge slightly for some time.
Right. Yep. So I agree. So when you're not sure about whether somebody has an INO, some INOs are very, very clear. Some INOs are more subtle. And a really nice way to bring that out is to have the patient make horizontal saccades, kind of focus in between the eyes. Don't really look at the right eye, don't look at the left eye, and just look in between the eyes. And you'll kind of see one of the eyes when you have the patient look to the right, you'll see if they have a left INO that the left eye will just lag behind. The saccade is not conjugate. So everyone just kind of defocus, look in the middle there. And you can kind of see that left eye float behind the right eye. When the patient looks to the left, the adducting and abducting saccades to the left look good. When he's looking to the right, you see this eye just kind of float behind, lag behind. That adduction lag is a subtle sign that is the only sign you might see. There might not be any adduction paresis. The patient may be past the point or may just not have diplopia at all, and they might just have this adduction lag. This adduction lag commonly will cause a symptom of visual lag. That is, they feel like it takes their vision a second to catch up when they look quickly to one side. Patients will notice this. Patients will have symptoms referable to this. And the most common example I've encountered has been patients who are driving and they're trying to look through their rear view mirrors quickly, and they notice that the eyes just aren't sort of moving together. There's a visual lag. Okay. So what about the utricular-ocular motor pathway? We talked about what happens in the lateral medulla. So in this situation, now we are above the decussation. So this patient, this same patient who has a left INO, also has a left hypertropia and also had a rightward head tilt. So now we see that left eye come way down, left eye comes way down, left eye comes way down, and the head tilt is away from the lesion to the right side, and the ocular counter roll is in the same direction as the head tilt, again, away from the lesion. So this is a contraversive ocular tilt reaction because all of the tilting, all of the rolling occurs away from the lesion, away from the left MLF lesion. Now we can use the high-high rule. So here we are at the level of the medial longitudinal fasciculus. We are higher than the decussation of the utricular-ocular motor fibers. We are higher than the pontomedullary junction in the pons. And the point here is that with an MLF lesion, you're almost always going to see a skew. If you see the patient acutely, these skews tend to be very transient. So if you don't look hard enough, or if the diplopia and the strabismus exam, the alignment exam, is sort of overshadowed by a big exotropia from the INO, you might forget about or lose the skew. And let me just show you this video again. Two things are happening. One is that the eye's coming down, but the eyes are also coming way in. See that comes up and in, up and in, up and in, up and in, up and in. And this one comes down and in, down and in, down and in. So the point here is that two things are happening. One is that there's a big vertical refixation from the skew deviation. And the second is that there's a big exotropia. That's because there's medial rectus paresis due to an INO, an internuclear ophthalmoplegia. So patients who have an acute MLF lesion will oftentimes complain of not simply vertical diplopia, not one on top of the other from a skew, not simply side by side diplopia from their INO, but more sort of diagonal as the horizontal and the vertical components come together. So a skew is very common with an acute MLF lesion, but they tend to be short-lived and transient, and they can go away pretty quickly. So again, we are higher than the decussation of the utricular motor pathways. The higher eye is on the same side as the lesion. So the hypertropic higher eye is ipsilesional if the injury occurs higher than the decussation of the utricular motor pathway. So low, in this case, the lesion was on the left side. This is a left lateral medullary stroke. The left eye was lower. It was a left-sided stroke. Now we're affecting the other side's pathway after it decussated, now that it's ascending via the medial longitudinal fasciculus, as these utricle pathways ascend in the medial longitudinal fasciculus along with the interneurons that, when affected, cause an INO. So this is the high rule. Here's another example of the high rule. This is a patient with a stroke involving the interstitial nucleus of Cajal. This is where sort of one of the final resting places, if you will, for the utricular motor pathways. And likewise, this patient with a left INC lesion had a big left hypertropia. The left eye was higher. The head tilt was to the right. The ocular counter roll was to the right. This was another example of a contraversive ocular tilt reaction, where the higher eye was on the side of the lesion because we are higher than the decussation of the utricular motor pathway. With all these different lesions, if I have a left lateral medullary stroke, the left eye will be lower. What if you had a right lateral medullary stroke? That's affecting the same pathway that we just talked about, starting from the right utricle. So if you had a right-sided medullary lesion, the right eye would be the lower eye. Now we're affecting the same pathway above the decussation. Now the left eye, the right eye is still the lower eye because it's the same pathway. The left eye is the higher eye. Up here, the left eye is the higher eye. So it's all about the company it keeps. We just talked about, if you see a skew, it does have localizing value, but you're going to see other features. If you have a right lateral medullary stroke, you're going to have rightward ocular lateral pulsion. You're going to have rightward dysmetria, ocular dysmetria. If you have a left MLF stroke, you'll have a left hypertropia, but you'll also have a left INO. If you have a left INC stroke, you'll have features of the INC syndrome, where you might have spontaneous torsional nystagmus. You might have vertical gaze-evoked nystagmus because the interstitial nucleus of Cajal is responsible for vertical and torsional gaze holding as well. So it's all about the company it keeps. But a skew deviation can absolutely have localizing value. What about the VOR, the vestibulo-ocular reflex? So I already mentioned two things that travel through the MLF. One is the utricular-ocular motor fibers. Two are the interneurons that connect the 6 nucleus to the contralateral medial rectus subnucleus in the midbrain. That's so that I can make a conjugate movement to the right, a conjugate movement to the left, so that there's not that adduction lag, there's not that adduction paresis as we see in INOs. But the other two things that travel through the same pathway, the same MLF, one are the anterior canal pathways. So if I pitch my head forward, I'm firing both anterior canals. That forces my eyes to go up. That's the vertical vestibulo-ocular reflex working. Again, firing the anterior canals, looking up. And also important to know that because these also decussate, if you have a left medial longitudinal fasciculus lesion, you're affecting the anterior canal pathways, the fibers that originated on the right side, on the opposite side. Likewise, the posterior canal, semicircular canal afferents are also going to pass, they're also going to decussate, and they're also going to pass through the MLF. They're going to ascend the MLF to get to their ocular motor nuclei. In this situation, if I pitch my head back, I'm activating the posterior canals, my eyes depress. This is, again, an example of the vertical vestibulo-ocular reflex. And part of the vertical vestibulo-ocular reflex passes through the medial longitudinal fasciculus. There's one single pathway for the posterior canal fibers, that is the MLF, whereas there are 3 separate pathways for the anterior canal pathways. So if you have an MLF lesion, unilateral or bilateral, you tend to affect the posterior canal pathways greater than the anterior canal pathways because there's only one posterior canal pathway as opposed to 3 anterior canal pathways. So if you have a left medial longitudinal fasciculus injury, you're going to damage those vertical semicircular canal pathways, the posterior and the anterior canal pathways that originated on the opposite side in the right labyrinth. So patients who have usually bilateral MLF lesions, if you have significant vertical semicircular canal weakness, these patients can experience a sort of so-called walking oscillopsia, that is a jumping of the world when they're moving their head, especially when walking. So be aware of that. That's a balance symptom that patients with MLF lesions, like MS patients who commonly have bilateral MLF lesions, bilateral INOs, can absolutely experience. They may have difficulty expressing this symptom to you, so you have to be aware of it.
Dan,
Yep, go ahead.
can I request you to go back 2 slides and explain this a little bit again? One more slide. The one about, yes. So here where you're saying that the skew deviation, the low, and the high, it is the same pathway. So how you will use, just elaborate on that, how you will use the skew deviation and the company to decide localization. Maybe you could just repeat that. And the second one about the anterior canal and the posterior canal, how they are going through the MLF. I think that will need a little explanation.
Okay. So again, if you affect the utricular-ocular motor pathway on the right side, let's say, patients with a right-sided medullary lesion, as we talked about, can have different ocular motor features. Patients might have a full-blown Wallenberg syndrome, where they have loss of sensation on the right side of the face and the left hemibody. They can have difficulty, they can have hoarseness and hiccups and difficulty swallowing. Patients can have a Horner syndrome on the right side. Patients can have ocular lateral pulsion to the right side. Patients can have hemiataxia involving the limbs on the right side. Patients can have lateral pulsion veering towards the right side. They can have dysmetric saccades, where the hypermetric saccades are going to deviate toward the side of lesion, toward the right side. So you're almost never going to see just the skew deviation. I've never encountered, nor have I read about a patient who had a lateral medullary syndrome that manifests only with a skew deviation and absolutely nothing else. So the best way to localize a skew deviation if it's coming from the lateral medulla is the company it keeps by doing a complete neurologic exam. That being said, the ocular, motor, and neuroophthalmic exam is usually all you need to do. Like I said, if I see some hypermetric saccades to the right and there's a right-sided Horner syndrome, I already know where it's going to be. If the patient has a skew deviation, the right eye is going to be the lower eye because we are low. We are a right-sided lesion. The right eye is the lower eye. We are lower than the decussation. If we affect this exact same pathway, after it crosses, now we are higher than the decussation. Now we are ascending via the medial longitudinal fasciculus. And likewise, it's extremely rare to have a skew deviation in the absence of any other ocular motor features due to an MLF lesion. If you have a skew deviation where now the right eye is still going to be the lower eye, but if you wanted to say sort of high, the left eye is the higher eye, the right eye is the lower eye. In this situation, again, the left eye is the higher eye. We're in the INC, we're in the MLF, it doesn't matter. High, the higher eye is going to be ipsilateral to the side of the lesion, higher than this decussation, but it's going to be all about the company it keeps. If you have a skew deviation from an MLF lesion, you are almost always going to see an internuclear ophthalmoplegia on the left side in this case. As we ascend further up the medial longitudinal fasciculus, if you have an INC lesion, still we are higher than the decussation. So the higher eye is going to be ipsilateral to the stroke, ipsilateral to the side of the lesion. But if you have an INC stroke, you're commonly in the acute setting, you'll also have spontaneous torsional nystagmus. You'll also have vertical gaze-evoked nystagmus. Because there are lots of other structures around the INC, you might have partial or complete third nerve palsy, which if you have a concurrent skew deviation and a partial or complete third nerve palsy, that can be very hard to diagnose. But also the rostral interstitial medial longitudinal fasciculus is in this vicinity. So patients can also have vertical saccade palsies. If you have a vertical saccade palsy, you know that you're in the midbrain. And if you also have a skew, then you can figure out which side of the midbrain you're on. Did that help a little bit?
So can I just
absolutely
simplify it, and you tell me if this is oversimplification or am I wrong? So suppose you find skew deviation, the right eye is lower and the left eye is higher. So you've got a skew. Now if
so right eye's lower, left eye's higher. So we're either here,
yes,
or here.
Yes, so there are three locations, either right below the pons, or left at the level of the pons just above, or left at the level of the upper midbrain. So if you find the right eye ipsi pulsion along with the right eye being low, then that suggests that, and maybe if you find a Horner's on the right side, then probably it's a right lateral medullary stroke.
Absolutely.
Then if you find left eye, which is the higher eye, that also has an INO on the left side, that suggests probably the lesion is somewhere in the just above the pons.
Absolutely, it has to be there.
Yes, and then if you find a torsional, spontaneous torsional nystagmus, and if you also find vertical nystagmus, upbeat gaze evoke, that will suggest it's an INC lesion and it's higher in the midbrain.
Correct.
Okay, good. So even I am understanding now. Fine, thanks.
Okay, and so the other explanation, so if I move my head like this and I look at my thumb, I'm activating the horizontal semicircular canal pathways. This is the horizontal vestibulo-ocular reflex. The VOR, the vestibulo-ocular reflex, its purpose is to maintain fixation, to maintain clear vision, to allow you to keep your fovea on whatever target you're looking at. That's the purpose of the VOR, the vestibulo-ocular reflex. So this is responsible, this is firing my horizontal semicircular canals. Now I'm firing my vertical semicircular canals. I'm doing the same thing. This is the vertical vestibulo-ocular reflex. If I move the head down, then my eyes go up to keep my eyes on the target. And if I move my head down, pitch forward, then I'm activating my anterior canals. If I pitch the head back, then I'm activating the posterior canals. So anterior canals, posterior canals, anterior canals, posterior canals. So the clinical pearl here is that these vertical semicircular canal pathways that subserve the vertical vestibulo-ocular reflex all travel through the medial longitudinal fasciculus. And so you can have vertical semicircular canal hypofunction or bilateral vestibular loss involving the vertical semicircular canals only on the basis of central lesions, medial longitudinal fasciculus lesions. The other thing is that they do cross over. So if you do vertical head impulse, if you isolate each individual canal and do a head impulse, which you can do, if I'm just moving my head to the right, this is just really interrogating the right horizontal canal. This is a rightward head impulse test. This is a leftward head impulse test, but I can move and do this as well in this plane, where this is right anterior canal, this is left posterior canal. So you can individually do a head impulse in each of those canal planes. So if a patient has a left medial longitudinal fasciculus lesion with a left intranuclear ophthalmoplegia, because both the anterior canal pathways and the posterior canal pathways travel through that same piece of real estate, if you did head impulses in the planes of the right anterior canal, because the right anterior canal afferents are going to travel through the left medial longitudinal fasciculus, the right posterior canal afferents are going to travel through the left medial longitudinal fasciculus. If you did vertical semicircular canal testing head impulse or video head impulse in the planes of right anterior canal and right posterior canal, you could actually see hypofunction of the vestibulo-ocular reflex of the right posterior canal pathway, of the right anterior canal pathway on the basis of a left medial longitudinal fasciculus lesion. Did that make a little bit more sense?
You would have to do this like a head impulse, so a jerk, a fast one, or just even slow VOR.
So you can demonstrate this. So it has to be fast. It has to be a head impulse. You can demonstrate this doing dynamic visual acuity as well. So I'm having the patient look at an eye chart. I'm moving the head horizontally and they don't lose a single line. So with both eyes open, I have them read the 20/20 line, which they can read. Then I shake the head horizontally and they still read the 20/20 line. That same patient who has a unilateral medial longitudinal fasciculus lesion with a unilateral INO, if you do vertical head shaking, they might lose 2 or 3 or more lines. So that would be another way to evaluate the vertical semicircular canals, dynamic visual acuity, which you can do at the bedside. You can also do vertical bedside head impulses. You could also do vertical video head impulse testing. The vertical head impulse testing is a little bit more technically challenging. It can also be harder in older patients who have cervical spine issues because you don't want to go too far. What I often like to do is just test. I do a head impulse sort of just back and forward, back and forward. So you're not isolating one of the posterior canals by doing it like this. You're evaluating both posterior canals simultaneously. If you do it forward, you're evaluating both anterior canals simultaneously, but if one side isn't working, you will see a catch-up. But it can be a little challenging to evaluate the vertical semicircular canal function at the bedside. Video head impulse is a really good tool for this.
Okay, thank you.
Okay, so what about medial longitudinal fasciculus nystagmus? So 2 things happen. It is very common that if you catch a patient with a medial longitudinal fasciculus who has an INO in the acute setting, they will also have spontaneous nystagmus, and it's oftentimes dissociated torsional and vertical. By far the most common pattern is this, that you will have an upbeat torsional nystagmus, but it's more upbeat in one eye and it's more torsional in the opposite eye. Let me just show you an example of that. This is the same patient again, who has a left MLF lesion, who has a left INO, who has a left hypertropia due to a skew deviation. And look what's happening. He has combined upbeat torsional nystagmus, but there's more upbeating in the right eye, the contralateral eye, and there's more torsion in the left eye. So this dissociated vertical torsional nystagmus is very common with an acute MLF lesion. I've never seen it quite this prominent, which is why this is such a great example. Unfortunately, the camera used wasn't that great. But if you see, and we think that this is probably another manifestation of vertical semicircular canal asymmetry and or the utricle pathway asymmetry. So this is that same patient. This is the video oculography. This is just the right eye, but clearly you can see upbeating and torsional components. And the torsion here is ipsiversive. The torsion is toward the side of the lesion. His lesion's on the left side. The torsional fast phase, the top poles are beating towards the left ear, and there's more upbeat nystagmus in the right eye than in the left eye. So this dissociated spontaneous nystagmus is very common with an acute MLF lesion. And again, this is another manifestation that's very short-lived, very transient. You have to look closely for it. All right. Should I just take questions about the medulla and the MLF as opposed to talking about OPT for a couple minutes since I'm kind of out of time?
I think
What would you like me to do?
Yeah, let me see. 1 minute. What are the questions? Okay, Dr. Meenakshi Sundaram had given a talk of eye signs in the ICU, but many of them, I think you elaborated similar. Dr. Sanjeev asks, sir, the ipsipulsion of lateral medullary syndrome improves in time or not? Is it a transient phenomenon?
So it's a little bit longer lasting than the skew, for instance, but you can see it months later, years later, to a mild degree. The skew, especially the MLF skew, like I said, is very transient. Whether that's the result of if you have a skew related to a medullary lesion, you're affecting the vestibular nucleus oftentimes. If you affect the nucleus, that skew tends to be a little bit longer lasting. Also in the INC, in the interstitial nucleus of Cajal, if you have a skew due to a nuclear lesion, an INC lesion, that skew tends to persist for longer than it does in the MLF, for instance. If you have an MLF lesion, if you have a transient skew, we think that probably the nuclei above and below are able to sort of modulate that utricle activity to minimize the skew deviation.
Suppose there's a skew, there's an INO above the pons, but below the INC, then sometimes you may not be able to localize it.
Yeah, that's correct. I mean, again, that's the purpose of a comprehensive ocular motor and neurologic exam. Usually you can. There are absolutely cases where you can have a skew or you can have sort of multifocal posterior fossa disease or brainstem disease where you just can't say with certainty where that skew is coming from.
Okay. Then Dr. Meenakshi Sundaram is asking, in INO, if you find an adduction lag, does it suggest demyelination versus stroke where the adduction is absent? So can you, does absence of adduction or just adduction being fully present but lagging, is that telling about etiology or just severity of the lesion?
Just the severity of the lesion. So you can absolutely have an adduction lag or a severe adduction paresis due to demyelination or due to stroke or any other etiology.
Okay, I'll just clarify. We have been taught as undergraduates that INO means failure of adduction, but this failure can be mild or relative. So you don't have to have, the person may have full adduction, but it will just be slower than the abduction. So you'll find a lag. So the mildest form of INO will be a lag, then more severe will be failure of adduction, and very severe will be no adduction at all.
That's correct. So it is entirely possible, and I've seen lots and lots of really subtle INOs. Let me show you a video from my collection real quick if I can. Subtle, let me see here.
You'll have to share the screen.
Yep. All right, and can you see this?
Yeah.
Okay, so this patient has a right INO. This is a patient with a right medial longitudinal fasciculus syndrome due to multiple sclerosis. So again, defocus, look right here. This is a really subtle one. Look right here. And there's a little bit of floating of the right eye behind. Look right here. This is in slow motion. You see this just lags behind ever so slightly.
Very slight.
This is a really, really subtle right INO. And this patient had absolutely no diplopia. Here's another situation. Look right here. You see this just kind of floats behind a little bit. Here it is in slow motion. Slow motion makes everything easier. Do you see it float behind? Look right here.
There is also a little hypermetric saccade of the left eye, the abducting eye. In the earlier video.
Correct. And some of that, right, some of that can be compensatory. So if you're trying to ramp up innervation of the right medial rectus, that might consequently give you a little bit of hyperactivity on the left side. That's one of the potential theories for why patients have abducting nystagmus. But again, here's another really subtle example in slow motion. And you just watch this right eye just lags behind.
Yes.
Right eye lags behind. And it's really subtle. But if you look closely, horizontal saccades. And again, you see this left eye lags behind. See that left eye lags behind. But it gets all the way over. She didn't have a significant adduction paresis, but clearly the saccades are not the same speed.
Okay. How important is abducting eye nystagmus? In what percentage of INOs do you have abducting eye nystagmus? Because that is again something which many people think that is the important part. The important part is the abducting eye nystagmus or the reduced or the slowing of adduction.
Right. So certainly if you're not sure if somebody has a partial third nerve palsy and you see clear abducting nystagmus, then that tells you what it is. That being said, it's very, very rare to have a medial rectus paresis in complete isolation from a partial third, in the complete absence of any supra or infraduction paresis or eyelid involvement or pupil involvement. But if you see an adduction paresis or an adduction lag and that abducting nystagmus, that's really confirmatory for you that you're dealing with an INO lesion. That being said, patients with myasthenia gravis can also have what looks like an INO, and they can also have abducting nystagmus. So if you're trying to decide whether a patient has an INO versus a pseudo INO from myasthenia gravis, this is where these other sort of more sophisticated tests can come in handy. If the patient you think has a left INO versus a left pseudo INO, then that patient who has a left INO should have a catch-up saccade in the plane of the right posterior canal. So you could do video head impulse testing in vertical canals. And if you did see hypofunction in that, the expected vertical semicircular canal, you could say, you know what, this has to be a medial longitudinal fasciculus lesion rather than a pseudo INO from myasthenia.
Okay. Okay, that's very nice. Okay, Dr. Hemant Sant asks, does patient get diplopia with an INO or that means, is it a symptom or is it just a sign which the examiner finds out? Does the patient with INO have any symptom? You already told one symptom, that when they're driving and they're looking at the mirror, they may find the eye is lagging. Do they have
Right.
diplopia?
Yeah, so absolutely, particularly in the acute setting, and because, as everyone knows, MLF lesions and INOs are so common in patients with myasthenia, those patients, assuming normal binocular function, should have diplopia, especially if they're bilateral. If they're bilateral, then the eyes are really going out. They really have a big exotropia. But if a patient has multiple sclerosis and unilateral or bilateral INOs, but also has a history of optic neuritis so that their visual function isn't very good, it is entirely possible that that patient won't experience diplopia. But any patient who has an exotropia due to an INO who has good function, visual function in both eyes, should experience diplopia.
Does diplopia tend to be a little more common in a third nerve palsy as compared to INO?
No, I mean, I think they're pretty much the same, unless if you have a complete third nerve palsy, of course, and you have complete ptosis, then those patients don't have any have any diplopia.
Okay.
But I think that the rates are about the same.
Okay, then somebody is asking, can you use convergence to localize an INO? We used to have an anterior INO and posterior INO depending on whether convergence is spared or not. So what is
right? Yeah. So the thought is that if you are, because the convergence pathways don't have anything to do with the pons, and if you have a medial longitudinal fasciculus lesion, oftentimes it's due to affecting the MLFs in the pons, in the dorsal pons. So those convergence pathways innervate the medial rectus subnuclei in the midbrain, so they completely bypass the MLF. So a patient who has an adduction paresis in the right eye, let's say, due to a right INO, might not be able to adduct the eye past midline. But if you have the patient converge or look at a distant target and then at their nose, so they have to make a convergent saccade, or if you have them simply bring a stimulus like their thumb towards their nose, you might be able to overcome that adduction paresis with convergence. Again, I was trying to focus on sort of the less common features of the MLF syndrome, which is why I didn't go into that. But if the thought is that if you are a little bit more caudal in the pons, for instance, and you have an MLF lesion and an INO, you may be able to overcome that adduction paresis with convergence. If you're a little bit higher, if you're a little bit more rostral, if you're close to the subnucleus of the medial rectus, then you might not be able to overcome the medial rectus paresis, the adduction paresis with convergence. So it could have some localizing value, but its localizing value isn't that great. That being said, if you're trying to decide whether this patient has a partial right third nerve palsy that's causing a medial rectus problem versus a right INO that's causing a right medial rectus palsy, you will not be able to overcome a partial third with convergence, whereas you may be able to overcome that adduction paresis that's due to an INO.
Okay. Somebody is asking, how does the INC involvement cause torsional nystagmus? So can you just tell us a little bit about the INC syndrome?
Right. So this patient, I have another great video to show, but basically because the INC is responsible for vertical gaze holding and torsional gaze holding, if you have a left-sided INC lesion, that will oftentimes cause vertical gaze evoke. So the patient looks up, they have upbeating, they look down, they have downbeating, but also you're going to have some asymmetry in the torsional gaze holding system, which is going to cause a slow phase, top poles towards or away from the side of the lesion. And then you're going to see torsional nystagmus that's usually toward the side of the lesion. I can show you a quick example if you'd like to see that of an INC syndrome.
I'm hearing about torsional gaze holding. So,
yep, torsional gaze holding. That's the reason.
Yes.
And here's a quick example of the INC part. So left INC, he's got a skew, he's got vertical gaze evoked. Here's the skew. And again, you can see the left eye come way down. The right eye comes way up. This is a left INC lesion. He's got vertical gaze evoked nystagmus, down beating and down gaze, up beating and up gaze.
To the left. Ceiling.
So this patient actually had an RI-MLF syndrome in addition to an INC lesion, both syndromes. So his nystagmus was a little bit complicated. So I'll just stop there.
In RIMLF, he would have down gaze paresis also, no?
So RI-MLF, not necessarily down gaze palsy. So you'll have a saccadic palsy that's more down than up, but oftentimes that patient will be able to pursue a target downward and upward fully. The vestibulo-ocular reflex should be intact as well.
Okay. Okay, then somebody is asking what happens if there is involvement of the ipsilateral olivary and contralateral ICP? What happens to pulsion if both are affected?
All right, let me see. Let's go to the pathway here. So the question is, so can you see my screen?
Yeah.
Okay, so the question was what again?
What happens if you have ipsilateral olivary and contralateral ICP? What happens to pulsion?
So ipsilateral, inferior olive, and contralateral ICP.
Same, I suppose. Both.
Right. So these are just two pathways or two lesions along the exact same pathway. So you should have exactly the same thing. Like I said, if you have a lesion over on the right side here, just prior to the decussation, exactly the same thing will happen as if you have a lesion right here. So the eyes will drift to the left, but if you're talking about this lesion, you'll have contrapulsion. If you're talking about this lesion, you'll have ipsipulsion, but in both cases, you'll have a leftward ocular lateral pulsion.
What if you have a right inferior olive lesion or versus a left dorsal vermis lesion? They are the same pathway, but at different levels.
Correct. So again, it would be, in both cases, it would be leftward ocular lateral pulsion. But if you're talking about this lesion would cause contrapulsion. This lesion would cause ipsipulsion. But it's the same pathway.
Okay. Okay. Somebody, Dr. Muralidharan asks you, do you use caloric stimulation at all?
So I like the video head impulse test because it's just so fast. It's so non-invasive, and patients just really tolerate it well. Patients with migraines who you do calorics on will hate you. They will throw up and they will possibly never come see you again as a patient. In my opinion, I think you can get away with doing video head impulse in the vast majority of situations. One of the exceptions is Meniere's, where calorics can be more helpful than head impulse, bedside or video head impulse testing. But I almost exclusively use video head impulse testing these days, very rarely calorics for those reasons. Is anybody there?
Yes, I'm there.
Okay, just want to make sure I wasn't by myself. That being said, calorics and head impulse, video head impulse, are both testing the vestibulo-ocular reflex, but they're testing it in different ways. They're testing sort of different frequency, different parts of the VOR response. So the two can be complementary, but they're not interchangeable. They're not exactly the same test.
Okay, I think so far Dr. Kothari was responding to everything that you said, but I think he's gone offline,
Okay.
probably. So there are, can you see the question and answers which are in front of you? Would you want to
So
take them up,
I'm
or would you?
oh, the Q&A.
Yes.
I can.
Or
Sorry.
yeah, he's back. He's back.
But now, Manasi, I think you'll have to read the questions or mail me the questions, because now the questions are.
Oh, you're okay. Okay. All right. So I will do that.
Dan, you can read the questions.
Okay, and I can see them. Can you please spell out the decussation you're saying? So decussation, just the crossing of the fibers, and let's see.
You can mail me.
Caloric stimulation.
Okay, sir. Right now. Okay. I'll try and do that.
Okay.
So convergence we talked about, and can we see a skew with a 1.5 syndrome? I don't think I have a good, yes, you can. I'm sorry. I thought I was asking, can I show a video of that? But with a 1.5 syndrome, you're going to affect the 6 nucleus that causes the horizontal gaze palsy. And you're also going to affect the ipsilateral medial longitudinal fasciculus, causing an ipsilateral internuclear ophthalmoplegia. So it is possible that you can have a skew deviation on the basis of affecting the MLF. I don't have a good example to show.
Do you have to have a skew deviation when you have an internuclear ophthalmoplegia?
So in my experience, if you look hard enough and you see the patient acutely enough, you will see one almost all of the time. It's very hard.
Will that not help you to distinguish between a medial rectus palsy and INO?
So it can, because if you're talking about a partial third.
Yes.
So if you have a partial third, so a skew deviation by definition is a non-paralytic vertical ocular motor misalignment.
Yes.
Whereas a third nerve palsy, if your eyes are like this from a third nerve palsy, there's going to be a supraduction paresis or an infraduction paresis that's responsible for that big vertical ocular motor misalignment. Whereas a skew, your eyes can be like this, but if you cover each eye individually, they should be able to move fully up and down because it's a non-paralytic problem.
What is inverse INO? Dr. Seema Shahi asks.
I'm sorry, an inverse INO?
I have not heard about it.
I'm not familiar with that.
Even I am not. Okay, then
Yeah.
Dr. Debbie Liquid asks, what are the eye signs for thalamic lesions? Just the most common. I think today we are not talking about thalamic because we are mainly brainstem ones. So we'll take that at some other time. Somebody is asking, what is the difference between external ophthalmoplegia and internal ophthalmoplegia? So
external ophthalmoplegia just refers to, so if somebody has a third nerve palsy, the external ophthalmoplegia part will be the ptosis, the levator weakness, the supraduction, infraduction, medial rectus paresis. That's the external ophthalmoplegia. If you have internal ophthalmoplegia, that simply means if you have a third nerve palsy, then you're going to have a midriatic pupil, a large pupil. That's all that means.
Then somebody is asking, what is the exact location of the utricle motor pathway? He's saying, I mean, high and low division, is it pons? So I think,
yeah, so it's sort of the pontomedullary junction.
Yes. Dr. Jacob George says, I find the SVV bucket test very useful to confirm a skew. If a skew is present, there will be usually 8 to 10 degrees of SVV, subjective visual vertical tilt.
Right. So again, if you have, let's say, a left-sided MLF lesion, you're going to have a left hypertropia. That's a skew deviation. Your eyes, your head's going to be tilted to the right. The ocular counter roll is going to be towards the right. This is contraversive. Everything's away from the side of the lesion. And the perceptual consequence of the ocular tilt reaction is that your brain will think that this is now earth vertical, even though this is at earth vertical. So again, the head tilt, all of the sort of the ocular tilt reaction is thought to be sort of compensatory because the brain thinks it's bringing the head from here to here, when in fact it's bringing the head from here to here. The subjective visual vertical that can be measured with a bucket measures the patient's perception of earth vertical, which should also be contraversive with the medial longitudinal fasciculus lesion in the same direction as the ocular tilt reaction and everything else. So I agree, the SVV can be very helpful, and you can think of it as sort of the fourth component, the perceptual component of the ocular tilt reaction.
But the SVV will be subjective, while what you are observing will always be more objective. So it will, I mean, though it is, after all, it is a subjective thing. So the patient may feel that or may not feel.
Yep, that's correct. But for instance, if you can't dilate the eyes, or if you don't have a fundus camera to appreciate the ocular counter roll, you can also do monocular bucket testing. So each eye individually, you'll see that there's subjectively a big torsional component in the left eye, and monocular bucket, other eye, you'll see that both of the eyes are sort of tilted and going in the same direction. So it can be helpful for that as well.
Oh, never thought of monocular bucket.
Yep, monocular bucket. Monocular bucket's also helpful for a fourth nerve palsy. So if you have a left fourth nerve palsy, the left eye is higher and the eye is going to be held in sort of relative X-cycloduction. So if you do the bucket tests with the good eye, it'll be pretty straight, and with the bad eye, it'll go in the direction of the cycloduction.
Okay, somebody is asking, how does climbing fiber involvement cause disinhibition of the vermis? So I think you've got that figure there in your.
Right. So the ICP, the climbing fibers, are inhibitory. They inhibit the Purkinje fibers, the Purkinje cells of the dorsal vermis, and the dorsal vermis is also inhibitory. So if you remove inhibition of an inhibitory pathway, then you're going to have too much inhibition, which in this case is reflected on over inhibition or too much inhibition on the vestigial nucleus. The vestigial nucleus, which is usually excitatory, is now going to excite the structures that it's supposed to excite less than it would normally.
I think we'll have to call it a day. If what I shall do is, the questions which Mansi has sent me, I may send them off to you if there are any particularly important ones, and you could maybe answer them.
Sounds good.
So it was a great session. I think the oculopalatal will leave for another day, maybe
sounds good.
The next session that you do. This was a great session. Thank you.
Thank you.
Thank you, Dan.
Thanks, everyone. Stay safe.
Thank
Appreciate your attention.
Thank you. Bye.
Take care.